Hello everyone and welcome to my channel. So pedigree analysis, you know the importance of this topic, right? And it is a difficult topic because I know when I was appearing for Neet PG, this was one of my last minute revision topic and I did not understand the concepts and what was happening, why it was happening. And also obviously the names of the diseases is something which you have to read during your last days before Neet PG, but then the concept is something which you should understand, and no matter how many videos I watched, I didn't understand the concepts. So this is a small attempt from my side to kind of break down what is there in this pedigree analysis. I haven't shown any pedigree chart in this video, but I just wanted to clarify the concept that goes behind this. There are so many previous years questions, and every alternate year they keep asking this pedigree analysis and this Mendelian disorders. So this is a very concept based area from pathology, and without further ado, let's dive straight into this topic. Now, coming to this individual parts, let's talk about this now. So, mutations involving single genes typically follow either the autosomal dominant pattern, autosomal recessive pattern, and X-linked, in which we have X-linked recessive and X-linked dominant, where X-linked recessive is more predominant. Okay? Now, each of this, please pay very good attention here because this is difficult but very important. So, the first is autosomal dominant disorders. Now, these are manifested in the heterozygous state. Very important point. All these points are important. So, at least one parent of an index case is usually affected. Usually, one parent is affected and then the children are getting affected. Okay. Both males and females are affected. Very important points. There is no sex predilection here, and both can transmit the disease. With an affected person, every child has one chance in the two of having the disease. Now there's a contradictory statement here that, see, it is written over here that at least one parent of an index case is usually affected. Again, it is written here that with every autosomal dominant disorder, some proportion of the patients do not have affected parents. So if the patient is not having affected parents, then such patients will have this because there are some kind of new mutations happening either in the egg or in the sperm. So there can be situations where the parents are not affected, the children are affected. There can be some instances like this, and it is because of the new mutations arising. Essentially, in autosomal dominant disorders, at least one parent is usually affected, but this can also be the circumstance. Okay. Now, I already have one important, point mentioned here, but I'll come to it later. First, I'll be reading about these points here. Clinical features can be modified by variation in the penetrance and expressivity. Again, important points. What is penetrance? I've already explained this before, that some individuals inherit the gene but are phenotypically normal. This is called as incomplete penetrance, means in spite of inheriting the gene, these individuals are not expressing the disease. They are phenotypically normal, and this is called as incomplete penetrance. Okay, thus 50% penetrance indicate that 50% of those who carry the gene express the trait. So if there are 100 people, 50% means 50% of the people who carry the gene, they only express the trait, not the entire population. And what is variable expressivity? It means that if a trait is seen in all individuals carrying the mutant gene, it is expressed differently among different individuals. So whatever mutation has happened or whatever mutant gene is present, it is expressing differently in different individuals, and that is called as variable expressivity. Example is neurofibromatosis type 1, because you see in some people you have the brownish spots, in some people you have the skeletal deformities. So the expression is different in different people, but the mutation is the same, and this is called as variable expressivity. So do not get confused with these words. Okay. In many conditions, the age at onset is delayed. Symptoms and signs may not appear until adulthood. In contrast to autosomal recessive, in autosomal recessive disorders, the disorders are usually expressed at birth or during childhood itself, but in autosomal dominant disorders, the age of onset is delayed. The molecular mechanism of the autosomal dominant disorders depend on the nature of the mutation and the type of the protein affected. Both are important. Okay? So what are the mechanisms? Number one, diseases involved in regulation of complex metabolic pathways that are subject to feedback inhibition. So any kind of feedback inhibition, if it is not regulated properly, then that can lead to this kind of diseases, for example, in the familial hypercholesterolemia. Okay. Next point is the key structural proteins like collagen and cytoskeletal elements of the red cell membrane if these are affected. For example, if you see here that the collagen molecule is a trimer, this has got three parts, okay, in which the three collagen chains are arranged in a helical configuration. Each of these three collagen in the helix must be normal for the assembly and the stability of the molecule. But even with a single mutant collagen, the normal collagen cannot be formed, and there is a marked deficiency of collagen. In this instance, the mutant allele is called as a dominant negative. Means if one of them is not functioning, this mutant allele which is not giving rise to a proper chain, proper collagen chain, this allele is called as dominant negative, and because of this the entire collagen formation is defective now. And this happens in osteogenesis imperfecta, characterized by marked deficiency of collagen and several skeletal abnormalities. Now loss of function mutations are more common, and less common are the gain of function mutations, in which there is an increase in the normal function of a protein. Okay. Another point to note here is that the gain of function mutations are almost always autosomal dominant. Question. Okay, so autosomal dominant can be correlated to the gain of function. Important question. For example, in the Huntington disease. Okay, again, this is a disease where you see there is a trinucleotide repeat mutation, production of an abnormal protein called huntingtin, which is toxic to the neurons, and hence even the heterozygotes develop a neurological defect. So okay, so now coming to this, that in the autosomal dominant, what are the points that I must remember? So you can see here is a pedigree. This is the affected individual because it is AA, and in the autosomal dominant state, this is getting affected. So it is going to be AA, which is the affected one. Homozygous may obviously it is normal because this autosomal dominant, so this will not have any disease. And this is the pedigree result, as you can see. 50% of the child is having the disease. So here every child has 50% chance of getting affected. This is the most common Mendelian pattern. At least one parent is affected. You can see one parent is affected. But again, this has got one disclaimer which I've explained before. Male, female are equally affected. There is two very important points to remember is that autosomal dominant disorders have got the tendency of incomplete penetrance and variable expressivity. Very, very important question. The explanation I have just done now. Now, one thing I want to mention here is that these charts, ठीक है, जो कि यहाँ पर दिया हुआ है, these diseases, each of these diseases, whether they are autosomal dominant, here you have the chart of autosomal recessive, ठीक है, here you have the chart of X-linked recessive, and X-linked dominant में you just have got these two examples, okay, but these three charts that I have mentioned here are extremely important. Each of these is a question anywhere or the other. It can be framed that what kind of inheritance this disorder is following. So I personally do not believe that this much of information you can remember by a mnemonic, because mnemonic में इतना सारा information I don't personally favor that. So you can form a mnemonic, but again if the information is vast like this particular chart, then mnemonic will not help. That's my personal opinion. I believe that mnemonic can help you in remembering small concepts or small things. If the information is too much, then the mnemonic will also be very bulky, and in that case you will remember the mnemonic only. You will not remember the actual information here. How can you form a mnemonic over here? Even if you form, I don't think there is much relevance of that. So what I suggest you is that make these charts, take some screenshots of this chart or kind of write it down in a piece of paper and paste it on your wall, and every day or every weekly or monthly you have to just look at it. You just have to brush through it, and it will get imprinted in your mind in the long run. So things which are extremely volatile like this has got no concept, but you have to remember which is coming under what. Out of these, the most important ones you will automatically remember, because we will read extensively about that. It will automatically get imprinted in your mind. But the remaining diseases, once you start reading, just reading it over and over again, you will definitely get a hang of it. So my suggestion will be that write it down in a piece of paper and paste it on your wall, or take a screenshot and go through it every weekly or every let's say 2 weekly or 3 weekly, like that, because this can be very well asked in your Neet PG exams. Very, very important charts, you can't miss out on this. Okay, now coming to the next, which is the autosomal recessive disorders. They're the largest category. They occur when both the alleles are mutated. ठीक है, तो यहाँ पर आप देख सकते हैं, only when both the alleles are mutated, then this individual is getting affected. If any one of these is having a normal allele, then these are all unaffected. Only when both are mutated, then only this particular individual is getting affected. Now the points. This trait does not usually affect the parents. Very important. Does not usually affect the parents, but the siblings may show the disease. Siblings have one chance in 25% of having the trait. If the mutant gene occurs with a low frequency in the population, there is a strong likelihood that the affected individual is a product of the consanguineous marriage. So anywhere you find this word, answer is always going to be autosomal recessive. The expression of the defect tends to be more uniform than the autosomal dominant. So this is having a more uniform expression, important question, compared to the autosomal dominant ones. Complete penetrance. Over there, what did we see? Incomplete penetrance, right? We saw here incomplete penetrance and variable expressivity. Here we see that it is having a uniform expressivity and a complete penetrance. Important differences, important points. Onset is frequently early in life. Here we saw that the onset was delayed. Always contrast and compare and read. Although new mutations associated with recessive disorders do occur, but new mutations is rarely detected. Okay, so new mutations are not that much found here, but that can be seen in the autosomal dominant disorders, mind you. Many of the mutated genes code enzymes, and in the heterozygotes, equal amounts of normal and defective enzyme are synthesized. So enzyme defects are usually autosomal recessive. So the inborn errors of metabolism are almost always autosomal recessive. Very, very important points, and a very important point to correlate. Okay. So let's come to this now, this pedigree chart. As I've told you that, this is the how it is formed, and this is the pedigree chart where you see 25% of the children is only getting affected. So 25% risk of the siblings to have the disease. The male, female are equally affected, do not usually affect the parents. Expression is more uniform compared to autosomal dominant. There is no variable expressivity. Complete penetrance is common. Wherever you find the word consanguineous marriage, is going to be autosomal recessive. Onset is early in life. New mutations are rare. Enzyme synthesis is most commonly affected. Most inborn errors of metabolism follow this pattern of inheritance. So these things are very, very important, and I have made this review notes so that these are the utmost important points you can't miss out on. Now coming to something called as the X-linked disorders. Now this is a very conceptual part. Up till now, whatever is there, whatever I've told you, those were quite straightforward. But here is a very important concept, very easy, but again difficult. So I would request you to please listen to this twice if you feel. Please understand that all the sex-linked disorders are X-linked and almost all are recessive. Please understand, here there is no such thing called as Y-linked inheritance. Did you ever hear this word Y-linked inheritance? Why? Why there is no Y-linked inheritance? That is question number 1. Number 2 is, why is that these disorders are usually expressed in the males? Why does these X-linked disorders are usually expressed in the males? Again, question number 2. So these are the most 2 important questions that come to our mind whenever we read this topic called X-linked disorders. Now, they are almost always recessive. Very important question. There are very few X-linked dominant disorders in which the affected heterozygous female will pass to half of their sons and half of their daughters. I will show you this explanation by the pedigree chart, how this is happening, because at the end of the day, you only have to remember this point for your MCQ. Okay, but how it is happening, that is what you should know. Only then you will not get confused. So these are the 2 diseases which are having X-linked dominant inheritance. This you must remember this: vitamin D resistant rickets and Alport syndrome. And these are important points you must remember. but this is X-linked dominant, which are very few. The most important part is the X-linked recessive, which you need to understand. So the first question that we had with us is that why there is no Y-linked inheritance. And that is because the males with the mutations affecting the Y-linked gene are usually infertile. Okay, so if there is any Y-linked gene which is defective, which is mutated, then these males are usually infertile and there is no X-linked inheritance. Okay, this is the answer to the first question. Second question is more difficult to understand. It is saying that why these disorders are expressed only in the males. Now please listen to this very carefully. The Y chromosome is not homologous to the X chromosome, and so the mutant genes on the X chromosomes do not have corresponding alleles on the Y chromosome. Thus, males are said to be hemizygous for X-linked mutant genes, and so these disorders are expressed in the males. Did you understand anything? Okay, so what they are trying to explain is that the Y chromosome is not homologous to the X chromosome. So if you see X and Y and X and X, so you can see here that this X dot is affected gene, okay, and this XX is also an affected or mutated gene. So what they're saying is that the Y chromosome is not homologous to the X chromosome, means whatever whatever genes are there on the Y is different from the X, right? So the Y chromosome is not homologous, means whatever deficiencies are there in the Y, that cannot be compensated with the X chromosome because they are not homologous. But if you see this X and X, these both are having homologous genes. So if one of them is mutated, it can be easily compensated by the other X gene. Did you understand? The Y chromosome is not homologous to the X chromosome, means the genes on the Y chromosome, the alleles on the Y chromosomes are not homologous to the X chromosome. So if there's a defect in the X, the defect remains, there is no compensation. But if it is XX, then even if one of the X is mutated and defective, it is getting compensated by the alleles of the other normal X chromosome. Understood? So now you can see here that, see, this is the affected one and this is the normal one. So if the configuration is XX, which is a female, then the mutant gene on the X, this dot X dot chromosome, is having corresponding normal allele on the X chromosome. This is affected, but this is having corresponding normal allele on this normal chromosome, and therefore there's compensation happening. These two are having same genes, so if this is defective, this can come into play and this can save this. So there's compensation happening, and therefore these females are not affected and females are becoming only carriers. Females are becoming only carriers and females are not affected. This is a very important concept but very difficult to understand. Okay, on the other hand, if you talk about XY, this is defective, but this is not having any compensation. There is no X chromosome here, and the Y chromosome, the alleles of the Y chromosome is completely different. It is not homologous. So therefore, this will give rise to disease because there is no compensation, and this is a male. So therefore, the male is diseased, but the females are usually carriers. Did you understand this? I hope yes. So this was the concept. You must remember that these disorders are expressed in the males and the females are the carriers. An affected male does not transmit the disorder to his sons, but all the daughters are carriers. Okay? Affected male will not transmit to his sons, but the daughters are carriers. Important question. All these points you must remember, but to remember you must know the basis, otherwise you will get confused. Okay? So now here I will talk about this. Okay, so now coming to the points, this one I already explained, this is also explained. Now if you see this is a normal female and this is an affected male, then this is the pedigree. Here you can see that the daughters are carriers, right, and the sons are normal, right? So the affected male cannot transfer to the sons. You can see here male is affected, but the sons are normal. So affected male cannot transfer disease to the sons. The daughters are only carriers and the sons are normal. Very important question. Okay. पेडिग्री में तुमको यही देखना है ना, तो अंडरस्टैंडिंग तो तुमको चाहिए इसके लिए. Now if you see that the female is affected, if it is a homozygous, now it is no more a carrier. So now this female is affected because both the genes are defective, both the chromosomes are defective. So affected female in a homozygous state and a normal male, if you do this pedigree, you will see that all the sons are now affected and all the daughters are now carriers. Okay, so if the female is affected, then in the X-linked recessive inheritance, the sons will be affected, the daughters will be carriers. Very very important point. Based on the question, you must know what is the outcome. Okay. Next is, if the female is a carrier and the male is normal, then what will happen? Then you can see that 50% of the sons are affected. This son is affected, but this son is not affected. So 50% chance of the son getting affected if the female is a carrier and the male is normal. So these are the three different types or possibilities of pedigrees which you must know, and the outcome you must remember. And based on this, whenever the pedigree will come, you can solve it. So usually what happens is that, this is another point to understand, is that usually what happens is that this is a carrier female. Heterozygous means carrier. This is phenotypically normal. The female is just a carrier. The female is not expressing any disease. However, if this normal X gets inactivated due to random inactivation, then the disease is expressed. So this is normal, but somewhere if this gets inactivated, then this will be expressed. So now the disease will be expressed, but this doesn't usually happen. So therefore, the heterozygous express the disease partially. Important point. Just remember this point. This is the basis of understanding. Means usually what happens is that in a carrier female, usually what happens is that there is random inactivation of this normal X gene, and therefore the disease is expressed in the carrier females sometimes, but always this doesn't happen. And because this doesn't happen, therefore the heterozygotes, they do not express the disease always. They only express the disease partially in case of X-linked inheritance. I hope all the concepts are clear here and I don't need to go through it. Now coming to the X-linked dominant disorders, as I've explained you before, this is also important. Two important scenarios you'll be seeing over here. Okay. Number one, if the female is affected. So here what happens is, because it is dominant, so the heterozygous female is affected here. This is an affected female. Why? Because this is X-linked dominant. So डोमिनेंट कंडीशन में एक जीन भी डिफेक्टिव है, एक क्रोमोसोम भी डिफेक्टिव है, देन ओनली दिस इज गेटिंग अफेक्टेड. ओके, so this is an affected female and this is a normal male. So if this is the pedigree, then you can see that half of the sons are getting affected and half of the daughters are getting affected. Please remember, in case of X-linked recessive, homozygous states was getting, in case of X-linked recessive, the homozygous state was getting affected. This, if this was the configuration, then this symbolizes that the female is affected. But in X-linked dominant, this means that the female is affected. I just wanted to make sure that you understand this very much carefully. See, if you talk about X-linked recessive, then what is this? Tell me what is this, and tell me what is this in case of X-linked recessive. And in case of X-linked dominant, what is this? If this is how it is, means this chromosome is affected and this chromosome is normal. So this is a carrier. Why? Because it is X-linked recessive. Therefore, this is a carrier, and only in the recessive state, means only when both the chromosomes are getting affected, then only this is an affected or diseased female. ठीक है, मैं फीमेल की बात कर रही हूँ, मैं सिर्फ फीमेल्स की बात कर रही हूँ. Okay, and if it is X-linked dominant, then even if one chromosome is affected, this is affected. Here there is no carrier state. Even if one chromosome is defective, because it is dominant, this is affected. Similarly, you find in the autosomal dominant condition. See, what is this? And what is this? And what is this? This is affected. This is affected. This is nothing, normal, or rather I can say normal. And in the autosomal recessive, this is affected. This means affected. This means what? Normal. Right? So you must know this, otherwise we'll get confused. Now if I talk about this, so you can understand that here you can see that almost 50% of the sons are getting affected and 50% of the daughters are getting affected. There is no carrier over here. There is a dominant hetero expression. Hetero means in the heterozygous state there is an expression of the disease. That's what I'm trying to make you understand over here, that in the heterozygous state the disease is getting expressed in case of X-linked dominant inheritance. Okay, don't get confused. It is very easy, but you just need to go through it over and over again. And if the male is affected, you can see that if the male is affected and the female is normal, then this is the pedigree. Here you can see that all the daughters are affected. I'm using the word affected because this is X-linked dominant inheritance, so all the daughters are affected. You can see the sons are normal. None of the sons are affected. The sons are normal. And the examples are Alport syndrome and vitamin D resistant rickets. So this is the two scenarios and this is the two outcomes. Very, very important questions and very important in the concept building. So I hope that you understood this. This is a very difficult part to explain also, to understand also, but I tried to make it as simple as possible. I don't know how to make it even more simpler. So if you have any more doubt and if you still want me to revise it or kind of talk about it once more, you can definitely tell me that. I can post a separate video only on this if you are getting confused, but I think you will not get confused because it's very easy now. Okay, now let's talk about. Okay, so we are almost done with this part, and as I said, these charts, I just can't stress any more on the importance of these charts. You must go through it. Okay, very important. And now the next part that we were starting with is this. Now, what is the biochemical basis of this single gene disorders? So basically what's happening here is that alterations involving single genes, the genetic defect may lead to formation of an abnormal protein or a reduction in the output of the gene product. So usually there's a substrate forming a product by these intermediates and these enzymes, and finally whenever the product is formed, it is having a feedback inhibition by this on this initial enzyme, and if the intermediates accumulate, they are diverted to other minor pathways. So what can be the mechanisms for the single gene disorders? Number one, there can be enzyme defects and their consequences. Number two, there can be defects in the membrane receptors and the transport. Okay, yes, defects in the receptors and the transport, alteration in the structure, function and quality of the proteins, and the genetically determined adverse reaction to drugs. These are the four mechanisms by which these single gene defects happen. Now you can see that this chart is so important. I will read this chart with you. Just hold on. So what happens is, the first point is that mutations may result in the synthesis of an enzyme with reduced activity or reduced amount of a normal enzyme. So whenever there's a mutation, there may be reduced activity of an enzyme, reduced synthesis of an enzyme, or reduced production of a normal enzyme. So because of, if any of this enzyme is getting interrupted or mutated or blocked, then what will happen? This substrate will be accumulated, or any one of these intermediates will be accumulated. This will be diverted to minor pathways, and other products will be, other intermediates and other products which are not required, those will get generated, right? So, for example, you can see in the galactosemia, the galactose 1-phosphate uridyl transferase is getting affected or deficient, leading to accumulation of galactose and consequent tissue damage, right? Also, you can see in the cases of lysosomal storage disorders, so there's a deficiency of the degradative enzymes. The enzymes which degrade the lysosomes are defective, so the lysosomes are getting accumulated now. So these are very easy to understand. Next is that an enzyme defect can lead to metabolic block and a decreased amount of end product. For example, you can see that a deficiency of melanin may result from the lack of tyrosinase, and that gives rise to albinism. Failure to inactivate a tissue damaging substance, like in the case of an alpha antitrypsin deficiency. Whenever you see that there is an unchecked activity of protease, that will lead to destruction of the elastin, leading to pulmonary emphysema. So because of that deficiency of this antitrypsin, it is not being able to inactivate this elastase, and therefore now this this walls of the alveoli are getting destroyed. So this is just the outline of all the important points. There's not much to understand here, but you must know that these defects, the basis of these defects and the diseases linked with these defects. Okay, like defects in the receptors and transport systems is associated with cystic fibrosis and familial hypercholesterolemia. So these two again are important points. Okay, now alteration in the structure, function, quality of protein, for example, thalassemia, and defective structural proteins in the osteogenesis imperfecta, where you see there is defect in the collagen. Then in the hereditary spherocytosis, defect in the spectrin, muscular dystrophies, defect in the dystrophin. Now, what is this? Certain genetically determined enzyme deficiency are unmasked only after exposure of the affected individual to certain drugs known as pharmacogenetics, because you see that in normal conditions, the D6PD deficiency does not result in disease, but on administration of antimalarial drug like primaquine, there is a severe hemolytic anemia resulting from this, and that is why we say that the pharmacogenetics is important, because these deficiencies are getting unmasked only after they're exposed to certain drugs. Now, this is the first part of this. Now, if you talk about this, see, enzyme, this see. So, this is the protein type or the enzymes. These are the examples, and the molecular lesions. These are the diseases. So, this is a very important chart. See how to read this. अल्फा एंट्रोटिप्सिन में क्या होता है, एंजाइम इनहिबिटर काम करता है, ठीक है. व्हाट काइंड ऑफ म्यूटेशंस, मिससेंस म्यूटेशंस, एंड व्हाट हैपेंस इज एम्फाइसेमा. So alpha antitrypsin is related to missense mutation related to enzyme inhibitor. If you talk about the familiar hypercholesterolemia, then there's deletions happening here at the level of the receptor, where you can see low density LPL receptor is getting mutated or deleted, because of which this disease is taking place. Okay. Then if you talk about the phenylketonuria, then the enzyme responsible is phenylalanine hydroxylase. It's an enzyme, and there's splice site mutation happening here. Okay, Tay-Sachs disease may be same. This is the enzyme involved, splice site mutation happening. In the severe combined immunodeficiency, there's point mutations happening in the enzyme adenosine deaminase. All these points are important. I would encourage you to read this chart very, very thoroughly. In case of osteogenesis imperfecta, the deletions or point mutations in the collagen, which is a extracellular structure. And if you talk about the Marfan's syndrome, then the defect is in the fibrillin. Defect is that it is a missense mutation. Okay, then hemophilia may, the defect is in the factor 8. Defect is there in the hemostasis because of deletion, insertion, etc. So this is a chart which gives you an idea of the basis of these disorders, what kind of molecular lesion is there, whether it's deletion or mutation, which kind of deletion, which kind of mutation, which are the enzymes involved, whether it's an enzyme or it's a transport protein, or what kind of receptors are involved, and what are the kind of enzymes, so what are the particular enzymes or particular receptors involved, and what disease is giving rise to. This is a very important and a very easy to read chart. It will help you to build your concept.